I have presented a rather controversial topic on whether machine interpretation will replace physician interpretation in cardiology, or more specifically in nuclear cardiology. I'm a scientist. I work with machine learning and techniques to compute, for example, patient risk, or compute the probability of outcome or probability of a certain disease, like coronary artery disease, after a particular scan. Physicians they are a little anxious about these machine learning tools because maybe they feel the jobs has been taken away from them. We believe those are special, very important tools which will allow them to find the right answer for the patient, more accurate answer for the patient, and also it will be. I believe that it will allow them to provide the same answer no matter what hospitals. If it's the hospital like Cedars-Sinai, where we have the best experts, or if it's a hospital which is maybe in some small place where they don't do the scans so often. So I think those will be very valuable tools for the physicians. Machine learning is used now everywhere in Netflix, in many applications, and we're bringing it into cardiology, and we believe this will be of great help for this field. We're talking about software programs which is able to predict anything that can be predicted. So for example, if a physician is given 20 different variables, for example, a result of the test, but then they see the patient age, then they see the blood pressure, or what medications the patient take, whatever other information physician would use, machine learning techniques are able to take this information, and based on some large training population, will then predict what will happen to that patient within a few years, or what kind of disease this patient is most likely to have. And we are giving this in terms of probability of certain outcome. That's what could happen. Yeah, we don't have 100% diagnosis. I don't know of any test, imaging test, which will give you 100% diagnosis. It will be some kind of probability. Probability can be very high. It could be 95%, or it could be very low, like less than 1%. So, for example, if you find that probability is very low of heart attack or of coronary disease, then you can tell patient, look, within the next 5 years, you have very low probability of having the disease. You'll be fine. You're giving patient a warranty in a way, and we're quantifying it in a way that it will be understandable for the physician and for the patient. This will be cardiologists using this technology when they order tests, and they will be able to combine the results and see the results and integrate them in a way in this one score, which will then define what is the best thing to do for this particular patient. Yeah, and it is used in other fields. And I, for example, presented one example where insurance company is trying to predict how long the patient will stay in the hospital for the next year. That would allow them to optimize treatments and preventive treatments. So it is used in many applications, not just in medicine, but in medicine it's starting to get used. One of the obstacles is that in general we need a lot of data to train the systems accurately. And in certain fields, for example, on Amazon, when you have where it predicts what kind of thing is the best for you to buy, they have a lot of data. We don't have such a luxury with data. We're building registries, so we're trying to obtain more data from many sites. It's a bit of a hurdle this is a little bit understatement probably, but. We are able to get in certain applications we're able to get data sets where it's enough to train the systems to accurately predict outcomes such as myocardial infarction or death or obstructive disease. When I presented it, I think I tried to convey the message that it's really should not be controversial because it is about finding the best solution for the patient. So I think this is in the best interest of physicians to give the best answer. And in particular, if we have a particular test, we want to make that the best, most accurate answer from that test. So it should not be controversial. I think the only reason is that people somehow think that that it is taking away their jobs, and that is the only part of the controversy. I don't believe it's taking physicians' job. I think it will make their job more fulfilling, and because they will be dealing with a patient, and they will be given this precise probability scores which they can apply and talk with the patient about them. In general, in cardiology, we have a lot of different treatments at our disposal, and doctors have those tools available. So, for example, if you have a very high chance of heart attack, I presume the patient could be going for invasive treatment such as PCI or bypass, or maybe there are some new drugs which are very expensive, and maybe they have side effects, and maybe those drugs will be given only to this patient with the highest risk. By having this kind of precise quantitative risks scores, I think it will be easier to administer these treatments which have their pros and cons and side effects. On the other hand, if there is very low risk, then patient maybe we can withhold the treatment. So I think that is how it will be done. In cardiology, we are lucky that we have these treatments available. So I don't think if someone has a very high risk of heart attack, they will just tell patient to go home. It will be driven by the technological advancements of how good the imaging is, and then on the data advancement, how well we can analyze this data. I think one important thing to work on will be access to data, and I think we'll have to work maybe with in a bigger collaboration with many centers to try and pool the data and work together. Right now we're kind of working separately in different institutions on this, but I think with collaborative efforts we will be able to learn more and optimize these techniques even more.